Good evening, all, and welcome to the latest in our Facebook Live educational series. My name is Alec O'Dare. I'm the Managing Director for Wound Care People in the Journal of Community Nursing. Tonight's session is brought to you in partnership with L&R, so I'd like to thank those very much to start. And the title is Understanding Exudate and the Importance of Wound Bed Preparation. Two fantastic speakers with us tonight. We've got Georgina Ellis, who's a tissue viability nurse from the East Midlands, and Fiona Fox, who's a regional clinical advisor at L&R. So first and foremost, let me just check, Georgina and Fiona, that you can hear me and you can see me and everything was okay?
I can.
Yes, all good, thanks.
Excellent, good to hear it. And a thank you to not just L&R, but to every one of you joining us this evening. It's a lovely day here in Cardiff, so I'm sure there's lots of people who are sat in their gardens watching this on their phones and iPads with a glass of wine, which is fantastic. Do please tell us where you are watching from in the comments, and ask us as many questions as you can in the comments section, because after the presentation, I'll be coming back to have a live Q&A with Georgina and Fiona. As always, certificates will be available at the end. You can download those. Keep an eye out and bear with us if there are any technical issues. You'll see that we're working remotely. We have been testing this all afternoon, so we're not expecting any issues. Yeah, just do please bear with us. One thing to say now, and that is at the end, we're going to be showing some links to some things. So do be mindful of that. In particular, there's a QR code, which we'll be showing, which you can scan to get some samples of some products that we'll be talking about over the next hour. So do keep an eye out for that. That's it from me. Good luck, Georgina and Fiona. I'm going to hand over to you. I'm going to sit back and listen and read all the comments and the questions that are coming in, and I'll join you after the presentation for the Q&A.
Lovely, thank you, Alec, and thank you for asking me to speak this evening. I'm really pleased to be here. So this evening, we're focusing specifically on wound exudate and the importance of wound bed preparation. The contents of tonight's presentation will include the role of exudate and its production, the impact of excess exudate, assessment and management of wounds, and dressing solutions. And then I'm going to hand over to Fiona, and she will give you a presentation in more detail on wound bed preparation and biofilm management. So I'd like to start off talking about exudate and remind us that it's an essential part of wound healing. It plays such an essential role for normal wound healing to occur. And it does this by maintaining a moist wound bed environment. It's often misconceived as bad because we see it too often in high levels, having a negative impact on wound healing. So positive exudate, when exudate has a positive role in healing, it's achieved by supplying essential nutrients to allow the cells to function. It helps tissue repairing cells to move around where they're needed. And it allows autolysis to occur, which you may know as debridement to occur. So separation of the damaged tissue from the good tissue. In normal wound healing, the volume of exudate will decrease as the healing occurs. So what does wound exudate consist of? So wound exudate, sometimes known as wound fluid, consists of many multi-factors. It consists of water. It consists of nutrients for wound healing. It includes electrolytes, inflammatory mediators. Inflammatory mediators cause the fluid to move from the capillaries into the wound bed itself. There's also white blood cells, and these help to tackle infection and to clean up debris from the wound bed. We also have proteases in exudate, and these are enzymes that act on proteins by breaking them down. There's also growth factors to promote wound healing and waste products as well. So many components in the wound exudate itself. So what amount is the correct amount of exudate to promote wound healing? Well, too little is not positive. So if we've got too dry a wound, too little exudate, that will impair the diffusion. That means reduce the movement of the critical factors for wound healing. So what will happen is delayed wound healing, because we'll have delayed granulation tissue. We'll have a delay in capillary growth. So the whole wound healing process will be slowed down. If we have too much exudate, there will be a maceration of the peri-wound area. So you'll get that sogginess around the wound. We'll have delayed wound healing, and dressings will become very saturated too quickly. So too much exudate, which we see too often. So the optimal amount of wound exudate will allow the movement of growth factors and cell signaling factors, all these things that promote wound healing on a cellular level. It allows for nutrients in the wound and for debridement to occur. So how do we know what the optimal amount of wound healing, of exudate for wound healing is? That's quite difficult to describe, but I heard somebody describe it many years ago as an ice rink is quite a good analogy. So if you think an ice rink looks dry, but if you put your hand on it, it feels wet. So there is some moisture there. So that's how I describe the optimal amount of wound exudate. So what influences this exudate production and the quantity of exudate that we have? Well, there's several factors that influence this. One of them is the wound healing stage. There are 4 stages to wound healing, normal wound healing, and they all overlap slightly, but the 4 stages are hemostasis from the original wounding, moving on to inflammation, so the inflammatory stage, which is absolutely vital and key to wound healing. Then we've got the proliferation stage, where the new granulation tissue and epithelialization occurs, and the final stage, which is remodeling, the maturing stage. Okay. Now, the inflammation stage, the inflammatory stage, we get an increase in wound exudate, and that's normal because there's a wound and the body's reacting and sends in extra white blood cells. So there's more fluid there. So that's normal. Also, if there's debridement occurring. So autolytic debridement is when the body's debriding itself. Autolytic just means automatic, so the body's doing it itself. So debridement of the wound, getting rid of that dead tissue. But also if we're using wound management products as well to promote that debridement, that will increase the wound exudate levels. Okay, so that's the wound healing stage. Other factors that influence the amount of exudate are the local factors, such as the size of the wound. By default, the larger surface area of the wound, you're going to have more wound exudate. Also, the level of bacteria in the wound. So the level of bioburden in the wound, that's called. So the microbes there will increase the inflammatory stage and increase the wound exudate. The amount of edema we might have in the wounds, that's the swelling, will also increase wound exudate. Systemic factors can include medical conditions such as congestive cardiac failure, renal or liver failure, and practical factors. So the position of the wound. So the lower limb, for example, will have issues with limb dependency, where patients can't elevate their legs, for example. So there'll be more exudate. The type of wound as well. So if we've got a venous leg ulcer, for example, that will be a wetter wound than a diabetic foot ulcer. Inappropriate dressings and interventions. So if we're using dressings that aren't absorbent enough for the type of wound, or a patient is not having compression when they should for a venous leg ulcer, then again, we will have an increase in exudate that's very difficult to manage. So inflammation, I said that's the key factor and it's vital for wound healing to occur. What happens is that we get a release, like I mentioned previously, of these inflammatory mediators, causing more fluid to move from the capillaries into the wound bed and an increase in enzymes. So that increases our wound exudate level. Now, in hard to heal wounds, so wounds that are not healing as expected, this is heightened and ongoing the inflammation stage. So there will be an increase and prolonged release of fluid into the wound. So that will increase the exudate production. But also there'll be a higher risk of a higher amount of bacteria in that wound, creating a biofilm, which will also increase that response, so that exudate level. So the exudate in a chronic wound, so a hard to heal wound that's not healing as expected, will be different to that of an acute wound that's just occurred. So chronic wound exudate is different because not only does it contain water, but it also contains more cellular debris and enzymes. There's much higher levels of inflammatory mediators that cause the more fluid into the wound, and proteases as well. For example, matrix metalloproteases, you might have heard the term MMPs. So these proteins are in much higher levels and they can be quite destructive to the wound. So we also get that prolonged inflammatory phase with higher exudate. So it's quite cyclical. So the longer a wound is there, the higher levels of exudate, the higher levels of exudate will promote that inflammation. And that chronic wound exudate can be regarded as a wounding agent because it's more corrosive and more damaging to the wound. So it can actually cause a breakdown of the wound. So it's got negative impact on the wound. So how do we know good or bad exudate? So to summarise what I've mentioned, the bad exudate, so on negative impact on wound healing, is because we've got high levels of inflammatory mediators, which are encouraging more fluid from the capillaries to the wound bed. And the proteases, which are the enzymes which break down the proteins, are in excess. So there's a lot of those, and that can cause destruction. So we'll have a non-healing or slow to heal wound with these higher exudate levels. In a good level of exudate, we have promotion of healing because it's there in a positive way, promoting all the factors that we need. And the MMPs are inactive. They're less in number and not being destructive. And the exudate level, as it should do, reduces over time, promoting healing. So when we do have excess exudate, we get problems, as I'm sure you will have seen. We get peri-wound skin changes, that's around the wound. We get psychosocial effects on the patient. Remember, the patient is at the centre of this and will impact hugely on their quality of life. If they've got exudate levels that aren't contained, it will impact on potentially all their activities of living. So it might prevent them from going out, it may prevent them from having visitors, it may cause the patient to become depressed, and all sorts of reasons what will impact on the wound: increased pain, increased odour, increased risk of infection, and increasing dressing changes as well. So that higher level of protein loss and electrolyte balance may need the patient to have their bloods checked more regularly, because that will cause systemic problems too. There's an international consensus document by the World Union of Wound Healing Societies called Wound Exudate, about effective assessment and management. A really useful document which summarises, as you can see in the flow chart on the right, which you can look at your leisure when you get the slides, but summarises the three main factors that we need to manage correctly to manage wound exudate. So in summary, we need to manage the factors that contribute to the wound and the abnormal quantity and composition of exudate. So that's looking at the medical reasons and all the reasons around in your holistic assessment, what is contributing to that wound becoming a hard to heal wound with abnormal exudate levels. We need to optimise the wound bed and the peri-wound skin by thinking about cleansing and debriding that wound. And Fiona is going to go into more detail on wound bed preparation. And we need to look at managing the peri-wound skin. And the third strand of this is managing exudate with the appropriate dressings as well. So whilst you're managing the other two factors, we need to manage the fluid that's coming out of the wound at the current time. So when we look at wound exudate, we need to look at the components of it and do a full assessment. So we need to look at the patient in the centre of the holistic assessment. What are the patient's concerns? What are the patient's goals? We need to look at the wound itself. We're going to look at the TIMES framework shortly to go through wound assessment. So not just the exudate itself, but the whole TIMES framework. We need to look at the dressings currently in use, what's been previously used. Are they effective? How can we improve that if required? Assessing the exudate itself, and I'll talk more detail shortly on that. And looking at the peri-wound skin, so the skin immediately around the wound. And then we need to look at how we can manage the exudate and the related problems that we've identified. So looking at the exudate itself, if we look at the colour, the viscosity and the type of exudate, it will then aid us to looking at the cause and if that exudate is normal or not. If the colour is a pale amber, light red, pink, red on occasions, but the viscosity is thin and watery, and it's most likely normal exudate. If we can see that the exudate is becoming thicker or opaque, with the colours then of the yellow, tan or green or a milky colour, then we might suspect infection as part of our holistic assessment. So also, is the exudate controlled within the topical dressing? And if not, why not? Does the current dressing do what it's supposed to do? So is it the right dressing for that patient at that time? So we need to, after assessment, decide what our treatment goals are and what we're trying to achieve with these dressings. Because remember, the body should be healing the wound itself. The dressings we're putting on there is to create the best environment to promote that. So the TIMES framework. The TIMES framework is a national framework which gives us some consistency in how we should be assessing the wound itself. There's the TIMES or the TIMES framework out there, good frameworks. We're using the TIMES one in my local area, but the TIMES framework also includes repair and regeneration and social as well. So TIMES stands for T for tissue, I for infection, inflammation or biofilm, M is the moisture balance, E is the edges of the wound. Are they advancing, progressing, or are they undermining? And S for surrounding skin. So like I said, it's a structured approach. So I'll go through those in more detail. So T for tissue. So tissue, we need to describe what we see exactly in the wound. So are we seeing sloughy tissue, necrotic tissue? Are we seeing any exposed bone, tendon, for example? Or if it's a dehisced surgical wound, are we seeing any metalwork, any sutures, internal sutures, things like that? So describe what we're seeing. Okay. So the priority, if we've got necrotic or sloughy tissue in a wound, is to consider debridement. And we must consider this as part of a full holistic assessment to be safe, because not all patients are suitable for debridement. Although it's a priority to aid healing, we need to decide if it's a lower limb, if we've got good vascular supply, good arterial blood supply, if it's on the foot below the ankle line and the patient has diabetes, we need to consider whether they need referring to the high-risk foot team. So in cases of the lower limb, in those circumstances, we need to consider a multidisciplinary approach. But if we're happy with blood supply and it's in the patient's best interests at the time, then we can consider debridement. And we can do this by autolytic debridement, which I mentioned earlier, where we can add products to promote debridement. And products that will do this can be, for example, hydrogels, hydrocolloids, gelling fibres, honey dressings. Anything that adds moisture to a dressing will promote debridement by the body. So that's T for tissue, assessing the tissue. The I stands for infection and inflammation and biofilm. So bacteria within the wounds, as you will know, can proliferate and cause infection. An infection will delay wound healing as well as increase pain, exudate volume and malodor. This will slow down wound healing or make wounds, or make the wound deteriorate. It's important to differentiate between acute inflammation and infection. Like I said earlier, inflammation is a vital and key part of wound healing, and that when that occurs, there is a rush of white blood cells that enter the wound area. And that process can cause some redness with inflammation, if you can see the redness on the skin tone. So we can get a little bit of swelling, a little bit of redness there. So that's normal. So look for other signs of infection, if you're going to determine if the wound has a wound infection present. A collection of bacteria called a biofilm will also inhibit healing. A biofilm is a term used for, as I said, a collection of bacteria that are existing together. And in this collection of the biofilm, it will delay healing because they will become resistant to topical or systemic antimicrobials. So these biofilms, which we suspect are in the majority of non-healing wounds, need to be either disrupted or removed mechanically. And Fiona will go into more detail about a biofilm disruption and removing them, but it really is key to promoting wound healing in hard-to-heal wounds. So M, if we're going through the TIMES framework, remember we've done tissue, infection, and now moisture imbalance. The moisture, as I already mentioned, that exudate level is essential for wound healing. However, in high levels, it has an adverse effect on wound healing, and lower levels can be too dry for the normal wound healing process to occur. So it's all about the balance. So we need to absorb any excess exudate and protect the peri-wound skin when our exudate levels are higher. Okay, so dressing selection is key. Whilst we address why there's an increase, is the increase in exudate associated with infection, or is it associated with edema, systemic condition, the factors that I mentioned earlier. So we need to determine whether that patient needs compression on a leg ulceration, for example, or a systemic medical review required. So we're assessing those reasons, but in the meantime, dressing selection, well, is key. So we need to consider either superabsorbents for high to very high exudate, foams for your more moderate levels of exudate, gelling fibres will absorb, of course. And if we need to add moisture, then hydrogels and hydrocolloids and some of the honeys can donate fluids as well. So moving on to the E, so the wound edge, we need to look how healthy those wound edges are. If we've got rolling edges or undermining, then we need to look at the wound, the reason why the wound is not healing. Is it progressing or not? And do we need to refer to another professional if there's a problem, either your tissue viability team locally, or do we need to consider vascular dermatology diabetic foot team, for example? So consider multidisciplinary referral if that wound is not progressing. If the wound edges have a thick layer of hyperkeratosis, so that's your really thick, dry skin scales, or thick maceration right on the wound edges, then we need to consider some debridement, mechanical debridement, which Fiona will cover shortly. So dressing selections with the wound edges and the surrounding skin beyond that, we need to consider how healthy the tissue is. So if our skin surrounding the wound edge is becoming damaged with adhesives, we need to consider silicone dressings, for example. So consider what wound contact layer you've got, what sort of foam dressings, and non-adherent dressings in some cases. So moving on to S for times, the surrounding skin, we need to consider any other skin conditions such as hyperkeratosis, which is your thick skin plaques like in the photo there, any venous eczema. We need to consider the damage caused by exudate. So you can get very excoriated skin. It's called from high levels of exudate, and sometimes dermatitis, which is associated with that higher level of moisture, and inflammation as well. Consider inflammation of the skin and the cause of that. So our priority will be skin care. So looking at hygiene and protection of the peri-wound skin, and cleansing and debriding as well. So removing any of that excess dry skin, for example. So product selection in this case, we might want to think about emollients and barrier creams for preventing damage in the first place. Okay, so that's the times framework. So I'm now going to hand over to Fiona. Thank you, Fiona. You're going to talk about wound bed preparation now. Thank you.
Thanks, George, and good evening, everybody. It's lovely to be here. So my part of this evening is to focus a little bit more around wound bed preparation, and the link really between wound bed preparation and exudate is it's so close. Because what you do in terms of preparing the wound bed can have a hugely positive impact on that exudate production, which hopefully you will see as we go through the next few slides. So first of all, I'm going to talk to you a little bit about, sorry, I'm just going to move that. It's not working. Just bear with me. There we go. So first of all, I'm going to talk to you about what debridement is. So this definition of debridement is taken from the recently launched international consensus document that was launched literally this month. And this really helps us to understand what debridement is, not only in terms of removing that non-viable wound debris, such as your necrotic tissue and your slough, but also the living components that are also factors within the wound, such as the microorganisms and biofilm. This document really also highlights the goals of debriding and ensures that the methods of debridement are undertaken safely, at the right time, and within the boundaries of the healthcare professional sphere of practice. So a really good document to go and seek out and have a read of. So George has already mentioned cleansing and debriding, and of course we need to differentiate these two terms because they are different. So the clinical aims with cleansing and debridement are different, and as such cleansing shouldn't really be confused with debriding and certainly can't replace it. The primary objective of wound cleansing is to really minimise that bioburden and eliminate as much of that surface contaminant as possible and the debris and the bioburden from the wound, and really take it to that sort of clean wound environment. And usually cleansing either comes before or after debridement. And in contrast to cleansing, debridement aims to remove the microbial and non-microbial wound components, including all of that debris that sits in the wound, but also in terms of biofilm and foreign materials. And of course, the more we can remove those barriers to healing, the more we are going to enable the wound to progress on through the healing trajectory. So why should we debride? Well, we know that devitalised tissue is a physical barrier to healing. If the wound bed is covered in slough and devitalised tissue, it hasn't got much chance of healing unless we remove that devitalised tissue. It can also induce a chronic inflammation. So George talked about the wound going through that inflammatory phase, but what we don't want is for the wound to stay in the inflammatory phase. And of course, if we don't remove the devitalised tissue, unfortunately, the wound can get stuck in that inflammatory phase. It can also prevent effectiveness of our topical treatments, particularly our topical treatments to treat biofilm. So our antimicrobials won't be as effective. Even systemic antibiotics won't be as effective if we've got devitalised tissue within the wound bed. Very often, devitalised tissue will also underestimate the extent of a wound. If you can't see the wound clearly because there's so much surface devitalised tissue, you don't know what's going underneath that devitalised tissue. And of course, the devitalised tissue is an absolute sort of, soup for bacteria. It has all the nutrients that bacteria loves, and of course it will feed on that devitalised tissue, and of course then the bacterial burden, the bioburden will increase. Very often we can see that sometimes we don't see the signs of infection very clearly or very early because the devitalised tissue is masking or mimicking the wound that is okay, especially when there's a biofilm present. And ultimately, devitalised tissue, obviously because of the activity of bacteria, can contribute to a septic response. So if you were all here in front of me, and whenever I deliver a session face-to-face with healthcare professionals around wound bed preparation, I always ask them to raise their hands on how many of you actually debride or can debride. And it's quite interesting because some people sort of not sure, they don't know whether to put the hand up or not, because I think certainly for me, some years ago, I often thought of debridement as being something of a specialist skill, something that only could be done by people like tissue viability nurses or surgeons even. But of course, anybody really can debride, because any healthcare professional that has applied a wound dressing to a wound has help support autolytic debridement. So many of you sitting watching this evening will have enabled autolytic debridement by applying a dressing. Of course, there are specialist methods of debridement that do require extra knowledge, skills and competencies, and these include the methods such as surgical and sharp debridement, the use of larvae therapy and the more technical solutions. However, some methods of debridement are very easy to use and they do require very little training, and therefore they're ideal for general use for any healthcare professional to use, and in some cases even patients themselves. So to give you an example, modern mechanical debridement with monofilament fibre technology such as DebraSoft is precisely one of those methods of debridement that's very easy to use and can be used by anybody. So other methods of debridement, if you think about methods particularly that promote autolytic debridement, so these generally need an adjunct therapy such as that mechanical debridement that I've mentioned already, or selective sharp debridement. And these are products that have either chemical or chemomechanical properties, enzymatic products, osmotic products like your honeys or your hypertonic gels, and of course any dressing that aids autolytic debridement, your hydrocolloids, your gelling fibres and so on. There are standalone methods of debridement, so particularly your biological, which is your larvae therapy, but very often larvae therapy needs to be authorised by a specialist nurse like a tissue viability nurse or vascular nurse, so they're not always readily available. Mechanical debridement will do that standalone method of debridement, so such as DebraSoft. Your technical solutions like your hydrotherapy, your hydrosurgery or ultrasound, these require obviously extra equipment and extra skills and training to enable the clinician to perform this type of debridement safely. And then, of course, finally, that selective sharp debridement or surgical debridement, again, whether it's using a scalpel, scissors or curette, again, these need extra skills, knowledge and training usually to be able to perform these methods of debridement. So although there are a number of factors really that influence choice of debridement, very often it's down to a number of these factors. So the clinical and patient need, the clinician experience is really vital. You know, anybody that doesn't have the appropriate training and level of skill and knowledge to perform some of these more specialised methods of debridement, you know, you certainly wouldn't want to be doing it if you haven't had that extra training and level of knowledge and competency. So we've got to think about, you know, which of these is going to give us the results that we want, and how quickly and safely can we get those results. So unfortunately, when we don't debride, we know that the healing process is impeded. The removal of devitalised tissue with autolytic debridement, if we're relying on autolytic debridement alone, usually takes a lot longer. As George has already mentioned, the presence of devitalised tissue within the wound bed will increase exudate in terms of volume, and obviously that exudate levels, those high levels of exudate, particularly when it becomes a chronic wound, the chronic wound exudate is much more corrosive and damaging to the wound itself and also to the surrounding skin. When we get damage to the surrounding skin, that generally can cause, you know, extension of the wound. So a wound that, you know, it was sort of maybe 6 by 7 centimetres, within a week or a couple of weeks of exudate levels being really high, we'll start to measure the wound and we'll start to see the wound getting larger and larger. Bacteria and biofilm will certainly proliferate because, you know, the bacteria is being fed by the nutrients from that devitalised tissue that's still sitting in the wound bed. Very often the wound will become malodorous, and for patients that is something that, you know, odour is probably one of the big factors that has a really negative effect on patients. The smell is something that they just can't cope with. And of course, ultimately, we are leaving the patient at risk of developing a wound infection. And of course, with a wound infection, you know, the patient will become unwell and obviously can lead on to further problems like sepsis. So myself and George have both mentioned this evening about biofilm. So George has given you a really good, succinct explanation of what biofilm is. But, you know, why should we be concerned about biofilm? Well, we know that biofilm is this sort of aggregation of bacteria that's often embedded within the wound bed. And studies have shown that biofilm is present in over 78% of chronic wounds. So over 3/4 of chronic wounds will contain a biofilm. We also know that biofilm is most active on the wound edge and the peri-wound skin, hence why when we think about the times framework, not only for assessment, but also for wound bed preparation, it's really important that we consider the wound edges and the peri-wound skin, particularly when we suspect that there's a biofilm present. Debridement has been found to be one strategy that really supports our immune system in combating that biofilm-related infection. And by debriding, we can remove that bioburden from the wound, especially around those wound edges and the peri-wound skin. In a recent study that has been published last year, Debrisoft was actually shown to significantly reduce biofilm cells, completely independent of the organism that was causing the biofilm. So regardless of what that biofilm or why that biofilm is there and what organism is involved, Debrisoft will completely disrupt that biofilm and enable us to start breaking it down and ultimately get rid of it, because that's what we want to do. So if you read about biofilms, generally biofilms are something that we can't see, but certainly there will be signs and symptoms present in any wound that contains a biofilm. And like we've said, the majority of biofilms will be present in chronic wounds, just like this picture here. You can see there's a lot going on with that patient's lower leg. There's a lot of devitalised tissue. There's obviously a problem with exudate. You can see the maceration towards the heel of the patient. But certainly with a biofilm, these signs that we will see will indicate that there's a biofilm present. So where we stop seeing healing, there's a cessation, a complete halt in healing, or a delayed healing, hard to heal wound, then that's usually an indicator a biofilm is present. There's little response to appropriate therapy. So for this patient, for instance, we might already have this patient in appropriate compression using an appropriate topical dressing and superabsorbent, but something, the combination of that appropriate therapy isn't working. So why isn't it working? We would expect to see a change in exudate colour, as George has already mentioned. Normal wound fluid will be sort of straw-like, might be pinky red, quite thin in its consistency. Where we start to see this change in colour, it becomes more cloudy, more viscous. That is usually an indication that there's a bacterial burden there, very often a biofilm. The amount of exudate will certainly increase. The body's natural response is to try and get rid of this biofilm, to flush it out like it will do with debris within the wound bed. So we will see this, consistent increase in exudate where we would normally be expecting to see a gradual reduction. The granulation tissue will also change in texture. What you normally expect to see with healthy granulation tissue is quite a sort of bumpy, uneven surface. So if we start to see a sort of smooth surface for that granulation tissue, or a change in colour where it becomes either a pale pink, very pale, or in some cases quite red, so sort of quite a vibrant red, then that's a good indicator a biofilm is also present. The patient will probably report that they're experiencing increased pain at the wound site, particularly because as a result of that increased exudate, and that exudate is wounding the wound itself, but also the surrounding tissue as well, and the surrounding skin. Of course, with a biofilm, it's quite a clever bacteria because it doesn't actually cause the patient to have systemic signs of infection. So we wouldn't expect to see a patient with a high temperature or feeling unwell. They'd probably perhaps feel okay, apart from perhaps the increased pain and the feeling of despair because their exudate is leaking everywhere. But generally they would feel quite well. So the real priority here is reducing the bioburden within that wound with the least amount of damage to that local healthy tissue, and that can really help tip the balance in favour of healing. And ultimately that's what we want to, that's what we're aiming for, to get the patient healed. So how can we do that then? So the foundation, or the fundamental principle really of managing wound biofilm, is debridement. Disrupting and removing that biofilm by repeated vigorous activity such as cleansing and debridement in combination will help break up and physically disrupt that biofilm. And that's what we want to do. We want to break that sticky substance down that's covering the bacteria, and we can do that and achieve this really easily with Debrisoft. We then want to ensure that we inhibit the microbial cell-cell communication. We want to stop that bacteria from talking to each other and reforming. And the best way to do that is to introduce a antimicrobial. So in conjunction with your physical disruption of the biofilm and then adding in your antimicrobial to stem and inhibit that bacterial growth, we're going to be well on the way then to getting rid of this biofilm once and for all. However, biofilm is very clever at reforming, so we need to continue to prevent that biofilm reformation. So we need to continue to repeatedly Debrasoft the wound at each dressing change and continue with our antimicrobial dressing as your local wound care formulary recommends. And we would recommend, and the best practice statement on biofilm management also recommends that this process is undertaken for up to 14 days, and then we need to reevaluate and see, you know, what is working. Do we need to consider perhaps changing the antimicrobial if we're still not seeing any improvement? So I've mentioned Debrasoft, and Debrasoft really does help to reduce that and break down that biofilm. But, you know, why choose Debrasoft? Well, it is highly effective. It will absorb and remove debris and exudate from the wound bed and, of course, the surrounding skin. It's really easy to use, and it is very quick at what it does. So it has this sort of rapid outcome when you've used it. It's extremely well accepted by patients, and we've heard it's gentle on intact tissue, so it won't damage newly grown granulation tissue or epithelial tissue. And it's the only form of mechanical debridement that's recommended by the National Institutes for Health and Care Excellence. And in fact, the NICE committee concluded that the technology within Debrasoft is well tolerated by patients. It is likely to debride more wounds more quickly, and that's going to result in fewer nurse visits. And so in all, when you add all those together, it's a more cost-effective treatment to debride than other debridement methods. Now, as most of the people here that will be on the session this evening, you're probably all nurses, or you will be seeing patients with wounds. Everybody loves a case study, and we love to share case studies. So I'm going to talk you through a couple of case studies in relation to how Debrasoft was used. The first one, as you can see from this image, is a patient has a wound on their lower limb. It's covered by 100% slough. We can't see the extent of the wound because obviously the devitalised tissue is hiding that from us. We don't know what's going on underneath that slough. And if you were to apply your traditional wound dressings that aid or solicit debridement, I would guess, you know, in my own sort of clinical head, got my clinical head on, as that would take at least probably a week, sometimes 2 weeks, to get rid of all that devitalised tissue if I was using a hydrofibre or a hydrogel. So you imagine that patient needs 2 or 3 visits per week. However, by using mechanical debridement tool such as Debrasoft, we've been able to completely or almost completely get rid of this sloughy tissue. So this patient has cellulitis, post-cellulitis. The blisters that the patient had formed this sloughy, what appeared to be a wound. But as you can see, once we got rid of that sloughy tissue, it actually revealed that there wasn't really a wound there at all. There's a slight sort of dermal abrasion to the top part of the limb of the calf, but the rest of it, actually there was no wound there at all. And of course, if you think, you know, how long that would have taken, traditional methods such as wound dressings, we've been able to significantly reduce the amount of visits that patient required, and of course move that patient on. You know, they haven't got a wound, we can get them moved on to the next stage. As I've already mentioned, sometimes barriers to healing aren't visible, such as biofilm. And if you see this lower leg, you can see that the patient has a lot of hyperkeratosis. There's some very sort of superficial areas of wounds or superficial areas of dermal stripping. Now, if we use a special camera that fluoresces the limb, that will fluoresce bacteria, what you can see now is that limb has bacteria present. So So we can't see that with our own eyes, with the naked eye. But when we use a special fluorescent camera, we can see those sort of bright red pockets and also that sort of green hue that you can see over the majority of the leg. And that's telling us, or the camera's telling us, that there is bacteria there's bacteria present on the skin surface, but also underneath the skin debris as well. So with the first use of Debrasoft, you can see that we've got this immediate visible difference. We can see that we've got rid of all that hyperkeratosis, and we can see what we're dealing with in a better light from the naked eye. But again, if we fluoresce that limb, what we can also see is that Debrasoft has removed that sort of surface debris, the skin that's probably got a lot of bacteria sitting under those hyperkeratotic plaques, but it's revealed deeper pockets of bacteria and probably biofilm. So a second treatment of Debrasoft, you can see already, even after the second use of Debrasoft, that we're seeing an improvement in the condition of the patient's leg and the patient's skin. But when we fluoresce the limb again, we can see that we've managed to disrupt that bacteria, that biofilm, and really break down that biofilm so that it enables the antimicrobial that's been used in between the dressing changes or as part of the dressing regime. It's going to enable the antimicrobial to really penetrate, get past that biofilm and do its job properly. So, you know, practice, any practice, you know, we want to ensure, we want to be confident that it's supported by evidence. So in terms of Debrasoft, we know that Debrasoft is available for all wound shapes and sizes, including cavities and those hard to reach areas. It's the most evidence form of mechanical debridement, and it's been proven to reduce overall wound dressings and total wound care spend, and also obviously reduce the amount of nursing intervention, the nurse visits. It's indicated for all tissue types, including granulation tissue, and can help to reduce excess exudate, as we've seen, through getting that wound to progress through that natural healing trajectory. And again, as I've mentioned, it's the only form of mechanical debridement that is recommended by NICE. So if you want to learn more about Debrasoft itself, or you want to request a sample, then you will have these links to be able to refer to with the slides at the end of the session. You can also learn more about the Debrasoft family and how to tackle those chronic wounds by visiting Learn on Demand, which is our e-learning platform, and it's there, you know, for everybody to use. It's completely free and obviously there and accessible 24 hours a day. So that concludes my part of the evening, or my part of the presentation anyway. I'm going to hand you back to Alec, and we're going to take some questions. Thank you very much.
Thank you both. Very informative. I've just been reading through all of the comments and the questions. I'm just going to say that we normally say that if we don't get through to your question this evening, that we do keep a note of them, and then the presentation. A few of you have asked whether the presentation will be available. It will be available on our website from tomorrow. It'll be available immediately after this to rewatch if you so fancy on the Facebook page, and we'll answer any questions that we don't get through to tonight via PDF. Other than, and this is simply that this is not us ignoring them. There have been quite a few questions coming through about other products, other types of debridements, and I understand that everybody really wants to know about it, cleaning solutions and things like that. We have a policy that we won't comment on other products because we're not or Fiona isn't, I'm not, and we're not the experts in those products. We're only really comfortable to talk about the products that we have and share the experience and expertise. So please, you can find out information about those others, but we're here just specifically to talk about the cases that we've got. So well done both. There's tons of questions. We've got 10 minutes. So you ready to crack on if I try and get through some of them? Brilliant. Okay, so the first question is, how long should I use Debrasoft for, and how often should I generally debride a wound? Either one of you want to, Georgina, how about you take that?
Yeah, that's fine. in my local area, and I think it was the same.
Do you want me to take it, George?
No,
or
it's
do
fine.
you want to take it?
In my local area, and I think on your presentation as well, Fiona, we recommend 2 weeks before review, and I noticed your slide said the same. So yeah, 2 weeks and then review, and if you need to do further debridement or then continue, but at least review every couple of weeks. Fiona, I don't know if you've got anything to add to that.
Yeah, I would say, particularly if it's, you know, to treat a suspected biofilm, you know, you want to give it a couple of weeks in conjunction with your antimicrobials. And I think really to make sure that you're getting the best out of DebraSoft, you know, how long you debride or DebraSoft for, you know, it depends on a number of things really. You want to be doing it for at least 2 to 4 minutes minimum, and obviously depends on the size of the wound. So if you're treating a larger wound, then obviously you want to be, you know, DebraSofting over one area for at least a couple of minutes and then move on to the next and so on. So, you know, there's a couple of factors that will affect how long you would DebraSoft, but definitely, you know, each time you use DebraSoft, 2 to 4 minutes is probably sort of a good guide in a single area before you move on to the next part of the wound.
Okay, and then not just in terms of time for the individual wounds for each visit. You're talking about you perhaps use it until the wound is clean and healthy, and you're satisfied that it's being fully debrided, right?
Yeah.
Well, so we've got another question. I wrote down a couple of things. So there was loads of advice around when you should debride wounds, what types of wounds and things like that. And I was thinking, well, when shouldn't you debride a wound? And one of our questions actually that has come in from somebody on the audience said, our diabetic foot clinic doesn't debride their patients' wounds. Is there a reason for this? Who would like to take that?
I don't
Georgina,
mind.
I'm going to pass it over to you. So is there...
Yeah, that's fine. I'm not certain on the answer of that, I'm afraid, because our diabetic foot, the high-risk foot service, do actively debride when they go and visit them. A reason why they might not in specific cases could be a poor vascular supply, and they may be then referring on to the vascular team. But generally in our area, they do the sharp debridement, and they use the DebraSoft as well. But in collaboration with the vascular team. The only reason they wouldn't debride, I think, is for a poor blood supply and referral on. I don't know if you've got anything to add, Fiona.
So I'll add that there may be a slight lag here in terms of the timing between us and Fiona, but we've done loads of presentations on diabetic foot, and it's often the reason is exactly what you just said. It's often poor vascular.
Yeah, I think
it's difficult to know what the vascular situation is. Fiona, I think you've got a slight delay with us here, right? So we're going to crack on, So Georgina, are there any other situations then, or any other circumstances where you'd look at the wound and decide not to debride?
Yeah, it's if it's in the patient's best interest. So I'll give you an example. If it's an end of life scenario for a patient, it's about keeping the patient comfortable. So it might not be appropriate in that example. Other than that, it's about pain levels, are they controlled, and blood supply. And if lower on the foot, like we've already mentioned, if it's a high risk foot because the patient's got diabetes, then we do that in collaboration with the high risk foot team.
Okay, fabulous. The next question, Fiona, I'm going to pass this to you, Fiona, if you can hear me, right? And if I'm going to give you 5 seconds to answer. If you don't, then I'm going to pass it over to Georgina, just in case you've still got this big delay. So the question is, somebody's asked, what should I wet DebraSoft with, and can I squeeze it if I make it too wet? I think we may have lost Fiona. Georgina, do you know the answer to that? That's quite a sort of specific product question.
Well, you can use obviously water, saline, or if you're using an antiseptic solution like octenolin or Prontosan, you can use any of those products. But on the packet, it gives you a specific quantity of exudate to put in to that product. And if you put too much in, then it can reduce the
effect. Okay, so hopefully I'm not too delayed.
You can take over, Fiona.
Quite delayed. Okay, I'm just going to ask you another question, because there was quite a lot of talk around actually cleansing and sort of cleansing solutions, and there was I think Fiona was the one that started talking about the difference between cleansing and debriding, which was really interesting. So when you're talking about cleansing, I think Fiona, I wrote down that Fiona said that you would typically cleanse a wound before or after debriding, and I did wonder whether that should have been before and after. I'm not too sure. And if you're talking about it, it's interesting that you'd use water or saline. A few people talked about cleansing solutions. Does it make a difference whether you use just water or saline versus a cleansing solution?
I think it depends. You have to do a holistic assessment on the patient state, the patient's wound, decide if you need that antiseptic solution or not. That's what I would do. So if you've got overt signs of infection, then I'd definitely be going for an antiseptic solution. But if it's removal of suspected biofilm with no other overt signs of infection, then I'm sure saline would be adequate. It's about risk assessment.
I'm just going to check whether we've got Fiona back with us. Fiona, can you hear me in real time at the moment? That's a no, isn't it? That's so we'll crack on, Georgina. So there's a couple more questions. This is a really interesting one actually. So this says, what do I do if I make my patient's wound bleed when debriding? Can I use Debrasoft if my patient is on warfarin?
Okay. Now, if a patient's at high risk of bleeding, then you can use it with caution. That's what we recommend. I mean, if you've got a wound like a malignant wound, for example, with high risk of bleeding, then I would be extremely cautious about that one. But if they're on an anticoagulant, and there is a
I'm not sure that it is real time, Ali.
It definitely isn't.
So if a patient's on anticoagulant with a potential risk of bleeding, then I would go with caution, so gently. And if there are signs of bleeding, then stop and apply localized pressure. So it's about risk assessment. So it's not a no, but it's being aware of the risks and reducing your length of time and the pressure that you're applying.
Okay. There's a specific question on here actually, just about a different type of debridement, which says, can community nurses apply larvae therapy as there aren't enough TVNs in the community? But I've actually seen that question come in, and I saw quite a few different people from all over the country answer. So I think Fiona said that it's predominantly a specialist tool to use, and I saw lots of other people chip in and say that in our area you have to, these are the specific conditions or circumstances when you'd need to do it. And I've been talking a bit about larvae therapy today in a few meetings this afternoon, which is quite interesting. So I think we've probably got enough time for one more question. And then we're going to finish. And then if we stay on for 10 minutes, Fiona might be back. So we'll we'll see what happens. So the last question is, are systemic antibiotics still being overused or prescribed in chronic non-healing wounds? I'm not quite sure that's got to do with debridement, but that's the final question that we've been sent.
We've covered biofilms today, haven't we, and how they can become resistant. So I think in some cases, I believe they are, and that's what our medicines management group are working on, as they are in all areas, that it's about holistic assessment and looking at wound swab results as part of your holistic assessment, considering biofilm reduction. I think sometimes they are overprescribed, and yet these chronic wounds are showing signs of consistent biofilms that are not going to reduce without disrupting them and attempting to remove them topically. So I'm sure there are cases, significant cases. So it's about holistic assessment, and biofilm reduction will go a long way in hoping to reduce that. Ali.
Fabulous. Okay, well, I think that's it for the live Q&A. I just want to thank yourself, Georgina, and Fiona, and the team at Mole, and my team we're all working hard this evening. Thank everybody. Thank you very much, everybody who's joined us. There's a Facebook page on our JCN page, which is the Venus Legalsa Facebook page. It's supported by Eleanor. If you're not already a member, there are almost 3,000 members in there. That were basically people in there share best practice. There's been quite a lot of people asking what educational resources are available, and we post a lot of the stuff that Eleanor do as well as a lot of stuff that we do into there quite regularly. So have a look for that on our page, and please do go and join that group. The certificates will be available now. There should be a link in the comments section. When you download the certificate, what we've added today, which is slightly different, is we've added a QR code. So that QR code allows you, if you scan it, it takes you to a place where you'll be able to request a free sample from Eleanor, which is that's a great thing for them to do. And like you said, the Eleanor have a learn on demand section. We'll post the link on there, and we'll stick it into the Facebook group later for all you people asking about what additional education is available. So I think that's it. Thank you very much for everybody. We'll be back in a few weeks' time. We'll be back with Eleanor, I believe, on July the 4th. Which is both Independence Day and General Election Day. So an interesting day to come back for some more learning. Like I said, thank you very much. Have a good evening, everybody. Enjoy the rest of half term, and we look forward to seeing you all soon. Cheers. Bye bye.